I want to begin my presentations by acknowledging and thanking the second cohort participants who have generously participated in this study for 5 years. We will present our study entitled Understanding the Effect of CMV on gamma-delta T cells population in HIV patients starting antiretroviral therapy. Cytomegalovirus infection is prevalent in people with HIV and increases with age. Currently, it is non-eradicable and uses several immune evasion strategies to outsmart the immune system. The mostly asymptomatic but potentially dangerous in immunocompromised individuals. In advanced HIV disease, CMV causes retinitis, but it also persists at high levels in patients responding to antiretroviral therapy. It is an example how CMV replicates in retinal cells. It can encode more than 700 proteins. This can induce most arms of immune system, including gamma-delta T cells. And these immune cells can control viral spread, but viral tendency and chronic immune activations can persist. Gamma-delta T cells comprises of 0.5 to 6% of total T cells in peripheral circulations. Gamma-delta T cells are important against viruses and cancer. Most circulating in gamma-delta T cells are Vδ2 positive, while Vδ2 negative can reside in mucosal epithelium. Interestingly, gamma-delta T cells are expanded in CMV seropositive renal transplant patients and also healthy subjects. In people living with HIV, Vδ2 positive and Vδ2 negative ratio can be inverted. This might not recover on Earth. Furthermore, the burden of CMV was not investigated. So here we provide the data describing the role of CMV in people living with HIV starting antiretroviral therapy. This is the summary of our cohort that has a high percentage of CMV DNA positivity before they start antiretroviral therapy, and all patients have high level of CMV antibodies. Here we present a study of PPMC immunophenotyping of young HIV patients starting ART with age-matched healthy subjects as controls. HIV patients' PPMC was taken before antiretroviral therapy or V0 and after 6 months on ART V6, and half of HIV patients were CMV DNA positive at V0. The flow cytometry panels are describing gamma-delta T cells memory and NK markers. Clinical data of people living with HIV also collected consists of HIV, CMV, and cytokines data. Then building immunology data to clinical outcomes surrogate markers for cardiovascular disease. This is CIMT. And this is a gating strategy describing the gamma-delta T cell populations and observed markers in this study. We can see that in people living with HIV, the proportion of Vδ2 positive is much lower than healthy subjects. In contrast, the Vδ2 negative proportion is higher than healthy subjects, and this factor caused the inverted ratio of gamma-delta T cells in peripherals. And this condition is persisted before and after ART. Then we look at the gamma-delta T cells profiles. The Vδ2 positive gamma-delta T cells show high immune activations and memory phenotypes, and also express NK markers. These memory NK markers is commonly appear in CMV infections. However, this phenotype declines at V6, equal to healthy subjects, except an accumulation of TEMRA and LIR1 in the Vδ2 positive gamma-delta T cells in people living with HIV. When we look at Vδ2 negative gamma-delta T cells, it shows high immune activations that up to 6 months on ART, higher than healthy subjects, and it also shown high CD8 and CD16 at V0, but it decreased at V6. To assess the role of CMV, we correlate CMV DNA data and also CMV reactive antibody compared to gamma-delta T cells. We can see that the CMV DNA viral load and CMV reactive antibodies negatively correlated to V-delta to positive gamma delta T cells. Moreover, the CMV-reactive antibody directly associated with immune activation at V0. The immune activations consist of both gamma delta T cells, V-delta 2 positive and V-delta 2 negative, but the correlation disappears at V6. As mentioned before, CMV can infect endothelial cells. What we can learn from an uncommon variant of V-delta 2 negative gamma delta cells in peripheral blood, which originally abundant in tissue and organ. So, from various publications, we can see that gamma delta T cells expansions following CMV infections may promote cardiovascular disease. The evidence was by the presence of gamma delta T cells in atherosclerotic lesion. The T cells found in atherosclerotic lesions plaques display memory markers and also shown an increase of immune activation markers of HLA-DR. We have linked immunology data to CMT and also compared the association trends to the correlations between CMV-reactive antibody to cardiovascular surrogate markers, CIFT. We see the similar trends between the association of CMV-reactive antibody and also immune activation of V-delta 2 negative gamma delta T cells. When we stratified by the presence of CMV DNA at V0, we look these trends at V6 after antiretroviral therapy. In conclusions, we can see that CMV-reactive antibody linked to V-delta 2 positive gamma delta T cells depletions before and 6 months on Earth, and it is also linked to elevated of HLA-DR of gamma delta T cells before antiretroviral therapy. And in conclusions, we can see it is associated with inverted ratio of V-delta 2 positive and V-delta 2 negative gamma delta T cells, and also immune activation of gamma delta T cells. When they stratified by the presence of CMV DNA, we can see the correlation between V-delta 2 negative gamma delta T cells immune activations that link with elevated of CMT levels at 6 months on Earth. So, by this finding, this may suggest the increased risk of cardiovascular disease in HIV patients with high burden of CMV. I want to thank the Check-Indo team and to my supervisor from Curtin, Tricia, Sylvia, and also Sally. And I also want to thank to the head of virology lab that provides lab facility in Jakarta, and also to DAD who provides PhD scholarships. Thank you.